Everybody see the PowerPoint?
Yes.
All right, quick, easy, and to the point, because there's really not, it's pretty straightforward. Pain. Like I said before, pain is what? What is pain?
Subjective.
Subjective, which means what?
It's different for everybody.
It's what the patient says it is. It's different for everybody. If subjective means it is what the patient says. So, which is very hard for us to accept sometimes. If you do work in healthcare, you've seen, I'm sure, patients who are drug seeking and things like that. But for the sake of ATI and textbook nursing, pain, and even, honestly, that is the practice. Pain is what the patient says it is. If your patient is taking selfies, eating chips, talking on the phone, cracking up, and calling you to the room for more pain medicine, and they're telling you their pain is a 10 out of 10, all you can do is document that they are complaining of pain, 10 out of 10. You don't change that number. You don't change their assessment or their perception of pain. Even as badly if you're thinking like, oh, they're just faking. No, you don't do that. You're a nurse. And what they tell us is pain is what the patient says it is. So what is pain? It's an unpleasant sensory, emotional experience with actual or potential tissue damage. Patient obviously is the most reliable indicator of pain. So there are questions, I believe, either coming up or in your proctor, somewhere I've seen these questions asking, what is the most reliable indicator of pain for a 10-year-old, whatever. The most reliable indicator is that patient's complaint of pain, that patient's rating of their pain and everything. That is your most reliable indicator. It's not what their mom said. It's what the patient said. And it is the most common reason to seek healthcare. Most people, especially men, unless it has to do with their penis or severe pain, most men don't even go to the doctor. So pain is usually the thing that brings anybody to the doctor. Back pain, abdominal pain, head pain, whatever the case may be, pain is the reason people go to the hospital or doctor's office. It's subjective, like I said, and it should be assessed during every encounter. So just like you do vital signs, pain is what they call the 5th vital sign, and getting a pain rating and assessing if your patient is comfortable is part of that. Individuals with impaired communication or cognition, such as babies. Oh, Lord, difficult. It's supposed to be assessed, not asses. I'll fix that. But anyway, anybody who can't communicate for themselves, obviously is going to be more difficult to assess. You must use most appropriate scale, and we'll go over those scales in a minute. But there's different ways to assess and document pain. So pain is subjective. However, having a pain scale has now given you some objective data to describe their pain, if you follow me. So patients stating that they have abdominal pain, but now they're saying it's a 7 out of 10. 7 out of 10 gives you some objective data to work with. So when you contact the doctor, you can say, hey, Mrs. So-and-so is complaining of pain in her left ear. She rates it at a 6 out of 10, blah, blah, blah. That is pertinent information to know. Untreated or undertreated pain could lead to depression, delirium or confusion, and just overall poor health outcomes, and it causes an increase in healthcare costs. There's different types of pain, just like different types of illness. There's an acute pain. Acute pain is what you call protective. Acute pain, like, oh my God, I just burnt my finger, now I'm experiencing pain. That sensation is telling me, move my hand away from that hot surface. It's protective in nature, protecting your body. and it lasts temporarily. It can usually be reversed once the tissue, wherever the tissue damages, is healed. It depends the how severe the pain is. Obviously depends on what caused the pain to begin with. Chronic pain is ongoing, and it can be debilitating. It can cause people to have depression. It can cause people to commit suicide. Chronic pain can last a lifetime, or it can be time limited, depend on, maybe you have a spinal cord injury. You're probably going to have pain for more than 3 months. But maybe eventually you get to a point where you don't have pain. The chronic pain lasts longer than 3 months. Cancer can cause chronic pain, whole bunch of stuff. I mean, it's just all about the timing, how long that pain lasts. And it may not respond. People who have chronic pain, they start to build up a tolerance to medications, things like that. So it's more difficult to treat. Breakthrough pain is pain that occurs. Somebody have a question? Oh, okay. Breakthrough pain is just when you have that acute exacerbation of pain. So say you have back pain, but it's been going pretty good. You're taking your medication as prescribed. You wear a back brace, and really on a normal day-to-day basis, your pain is, 3 out of 10. All of a sudden it's winter, it's snowed, it's freezing cold. Now you are having serious breakthrough pain or acute on chronic pain. Another way to describe, way breakthrough pain is used would be like if you had it's still an acute pain and you've given them pain medicine and it's gotten better, but before the next dose of that long-acting med is due, they're starting to have breakthrough pain. The pain is not lasting as long as the drug and the pain is breaking through. But that is what you call breakthrough pain. Okay, so there's 2 types of pain. There's nociceptive and there is neurologic pain. Nociception is a term to describe basically just the ability to feel pain. It occurs, what's happening in the nociceptive process is you have a painful stimulus introduced. So say in this picture, the lady, her middle finger there, she touched fire, I don't know, and now she burnt the finger. So initially that painful stimulus of the heat was introduced to her finger, which then triggers a chemical response in the body. And we will go into more depth on that next week. But basically, the triggering is what's called transduction. And then these chemicals are released, including histamine, bradykinin, prostaglandins. These chemicals are released. What these chemicals do, and again, we will talk about them more next week with inflammation, but what they do is they cause vasodilation, which is going to open up the blood vessel and send more fluid and blood to that area. So it results in swelling. They are what bring the signal to your brain to tell you, wow, I'm having pain. They also neurotransmitters like dopamine. Dopamine is like a chemical that carries messages along the nerves. Again, we will talk about neurotransmitters when we get to neurology stuff, and we will talk more about those chemicals and histamine and prostaglandins next week. But for the sake of nociception and the nociceptive process, that's basically what happened. Something happened that was painful, whether you got poked with a needle, hit by a car, smacked in the head with a bat. Either way, a painful stimulus has now been introduced, chemicals are released, and a message is carried to the brain. And the other part of that was A message may also be carried to your skeletal muscle, initiating an involuntary movement. Like if you burn yourself, you don't stand there and say, oh my, this fire hurts. I am going to pull my hand away from this fire because it is hurting. No, you've been in burn up trying to do that. These are involuntary things that are happening rapidly in your body. So when those chemicals are released and those neurotransmitters bring that message to the brain tells the skeletal muscle, hurry up, get your hand out that fire. And so as soon as you feel the painful stimulus, you jerk back. That wasn't you telling, that wasn't a voluntary movement. It was involuntary from this transmission or carrying of the message to the brain and to the muscle cells. Perception, again, is like your perception, your brain's reaction to the pain. Everyone's perception is different. And because of that, because perception is just simply your brain's reaction, it can be manipulated by those non-pharmacological approaches, which we'll talk about next, such as distraction, guided imagery, meditation, things like that. Perception is going on in the brain, therefore we can distract the brain, hopefully, from having that perception of pain. Now, if you've been burned on 75% of your body, I'm pretty sure meditation is not going to do nothing for your pain. So within reason, okay, I'm not saying guided imagery is by in and of itself is a way to reduce pain. It just depends on how bad your pain is. Somatic or visceral. Somatic is, well, let's put it this way. Visceral means organ pain. So if you're having visceral pain, if you're having abdominal pain, like deep in your stomach, burning from an ulcer in your stomach, that's visceral pain. Every other part of the body is somatic. So soft tissues, ligaments, muscles, joints, bones, everything else but an actual organ is considered somatic pain. So all those parts of the body, except for nerves, pain occurring anywhere except the nerves is nociceptive pain. Does everybody understand that thus far? Great. So moving on, then you have, hold up, somebody in the chat, where you at? Hold on, chat. Whenever the chat comes up, I don't know why it's so slow to come up. Oh dear Jesus. Anyway, on to, if you have a real question and I don't see your chat, I'll get to it whenever this chat screen comes up. But neuropathic pain. When they say pathophysiologic, that means there's been some damage to the body, basically. Neuropathic pain is related to disease processes, nerve pain, whether it's like a degeneration of the nerves, if it's your nerves are all messed up because of like your peripheral nerves may be messed up from diabetes. And we'll talk about that later, but you know, uncontrolled diabetes damages your nerves. And then those people end up with neuropathy. So that is strictly related to nerves and damage to the peripheral or central nervous system. Periphery, everybody know what the periphery is? Peripheral, what does that mean?
Like your,
oh, what'd you say?
Your extremities.
Right, it means away from the body. So your arms, your legs, your head, your nose, whatever, your lips. That is your periphery, your peripheral nervous system. And then of course your spinal cord and your brain are your central nervous system. So it may occur in the absence of tissue damage and inflammation, because again, it could be just from years of degeneration of these nerves, or old injury, could be anything, but it doesn't necessarily have to be an inflammatory process to have nerve pain. Does anybody know what nerve pain feels like? I forgot to put that in here.
It's like sharp pain.
Yes, sharp, burning, pins and needles. That is how people describe. If your foot has ever fallen asleep and then when it wakes up and oh my God, you just feel like prickly pins all over your feet or your foot, whatever, that is nerve pain. That's what nerve pain feels like. That is what people with peripheral neuropathy feel like all the time. It is frustrating. It is obviously severely painful if your leg ever fell asleep and you felt that sensation. I couldn't imagine living like that. And just because I always like to put a story with stuff, honestly, my uncle 2 years ago, he beat lung cancer. He had small cell lung cancer, but the chemotherapy resulted in peripheral neuropathy. Would you believe that just like a month or two after he beat lung cancer, he committed suicide because he could not cope with how severe the neuropathy pain was and how debilitating it was for him. He even wrote in the letter that he left behind, that, not being able to feel his feet, not being able to drive anymore. And he was only 60 years old, not being able to ride his motorcycle. That pain was so debilitating that he could not imagine living the rest of his life like that. So pain has a serious effect on people's lives. Assessing pain. So like I said, you want to use the most appropriate scale. When you are assessing pain, this is a mnemonic you want to remember, PQRST. There's other ones in your book and on Lippincott too, but the easiest one for me is PQRST. What provokes the pain? Meaning what brings it on? What is the aggravating or alleviating factor? What causes you to have pain and what also relieves your pain? So when asking about pain, you want to know what provokes the pain. What is the quality of pain? Is it throbbing? Is it sharp? Is it shooting? Does it feel like pins and needles? Is it burning? What is the quality of pain? And does the pain radiate? Are you simply having abdominal pain or are you having abdominal pain that radiates to the back? Those things, all these things, help you to treat the pain, but can also help you to figure out what's causing the pain. Severity, obviously, is going to be how you rate your pain on a scale of 0 to 10, or looking at these cartoon faces, where do you rate your pain? And timing, is it chronic or is it acute? Is it, and even if it's chronic, is it a sudden onset? Does it all of a sudden just hit you out of nowhere? Or is it like gradually throughout the day? For example, when we go to musculoskeletal stuff later, osteoarthritis, usually the pain from osteoarthritis is the worst at night. It gradually builds up during the day because they've been doing activity and walking and doing all this stuff. And now by the end of the night, them joints are aching. So that would be more of a gradual onset of pain versus like, I went from 0 to 100 real quick, went from no pain to a 10 out of 10. So that's that. I don't think and then other things you may want to assess, like how does it affect their quality of life? Because like I said, we didn't know that my uncle complained about nerve pain and neuropathy, but we did not know that it was having that big of an impact on his life that he was actually thinking about ending it. So are they out of work? Have they lost their job, their car, and everything because of their pain? You need to know, like, how is that pain affecting their quality of work? And what is their goal when it comes to pain management? Like when you're working in the hospital with patients and you're going around to see them, if a patient just had a big abdominal surgery, a goal of 0 is probably unattainable when surgery was yesterday. But let's figure out what is their threshold for pain. They may say, look, give me some meds because my pain's a 10 out of 10. But when it's like a 4 or 5, I'm good. It's really just what they can handle. Everybody's pain is different, but what is their goal as far as pain management? In assessing pain, again, you got all these different scales. So this is the Wong-Baker FACES, which is similar to the Oucher scale below, except the Oucher scale uses actual photographs. These are scales that are used for children. I mean, you could use them. It's based on your developmental stage. So if you have an adult with, you know, profound mental retardation, or, you know, and they only function at the level of a 6-year-old, they may not be able to rate their pain from 0 to 10. So just show them the FACES if that's what you need to do. For infants, age, I think 2 to 7 months is what ATI says, you use this FLAC scale, and it's looking at FACES, and legs, activity, crying, consolability. And you can see that in your PEDS book. I don't know what doggone page that was, but it's on page 44. Is an example in the PEDS book of different pediatric scales. So that's that. Nonverbal pain. Sometimes, you know, people don't verbalize pain, or they can't speak for whatever reason. So you want to pay attention to nonverbal body cues with everybody. But when it comes to pain, facial grimace, are they frowned up? Are they, you know, looking, you know what a facial grimace is? Are they looking crazy in the face? Like something might be wrong. Are they crying? Are they moaning? You know, patient had a stroke and they have aphasia and they can't talk, but they're in their room and they won't stop crying and moaning. They may be in pain. Restlessness, agitation. Again, patients flipping and flopping in the bed. You can't get them to relax. It could be a sign of pain if they're not able to verbalize what they're going through. Withdrawal or guarding. Withdrawal would be like, you touch sometimes kids injure themselves and you don't know they hurt themselves at recess at school, and then they get home and maybe you go to touch their right arm and they snatch it back. Or are they walking around holding the arm? Or how this person in this picture, they're holding their head. That is what's considered guarding. And then withdrawal will be, of course, if you go to touch my right arm and I flinch and pull it away from you, that is withdrawal. Decreased attention. I can't even look. When people say my head hurts so bad, I can't even concentrate. That's a real thing. It decreases your attention span. It can cause delirium. Vital signs. It will cause your heart rate, respiratory rate, and blood pressure to go up. You know, you're in so much pain now, your pressure's up, got your pressure up, heart rate, heart beating fast, and everything. Things that influence pain would be age, gender, culture, fatigue. Obviously, if you're tired, your threshold or the level that you can tolerate pain is probably going to be much lower because you're tired, you're aggy, you don't want to be bothered. And then now you're in pain. Emotions, if you're depressed or something like that, it can kind of make you more sensitive to pain. Cognitive factors, and even mental health. Sadly, like some of these people with schizophrenia are kind of sometimes unaware of what's going on with them, and they tend to tolerate a much higher level of pain than a normal person would. Or, you know, if a person is mentally impaired, like maybe that Down syndrome, it will change how they perceive pain. Individuals at risk for under treatment of pain. Obviously, anybody who can't verbalize their pain, like infants and children. Also, sometimes infants and children, they're crying, can be mistaken for, you know, bad behavior, something like that. And anyone else who is nonverbal or able to express their pain obviously is going to be at risk for under treatment or non-treatment of their pain. Older adults, like it says in that first line, older adults sometimes have a higher threshold for pain, and then sometimes they don't. But a lot of times older adults will tell themselves that pain is just part of the aging process and I'm just getting old. And they won't mention the fact that they have been having severe pain because they feel like there's nothing to be done about it. It's just part of the aging process. So you have to approach different people differently. Undereducated, those people are always vulnerable. Again, knowledge is power, and the less that you know, the less likely you're going to speak up for yourself or even seek help. Substance abusers, just because somebody is addicted to heroin or addicted to cocaine or whatever, doesn't mean they don't experience pain. My biggest pet peeve is another big pet peeve, I shall say, is seeing people being mistreated because of their substance abuse or mental illness. Not right. It is not right. It is no reason why, if I have appendicitis and just got my appendix out, and you have appendicitis and you just got your appendix out in the exact same day, and you're prescribed, morphine or a PCA pump, and I have to suffer with Tylenol. That is not right. I mean, they're already substance abusers. You're not here. They're not going to quit using drugs, especially not right now while they're in pain. You're not here to be trying to promote sobriety. I mean, you want to promote sobriety, but this is not that right now. The patient is here. They had a surgery or what have you, or they broke their leg or whatever. They need proper pain management. And also those who fear addiction. People will avoid any type of pain medication like the plague. It's like you got two extremes. You got people who are so scared that they're going to get addicted that they never take anything and they just cope with pain. And then you have people who are already addicted to opiates and other substances. And one, their tolerance is high as hell. They require higher doses to even treat their pain because they're, using these drugs on a regular basis. So there's that. As far as pain management, the goal is you want optimal relief, the most pain relief you could give the person, or at least get them to a level where it is not affecting their quality of life. Like I said, some people, chronic pain and major injuries, I mean, some pain is unavoidable in some situations. I can't say that you're going to feel zero pain depending upon your issue, but at least if we could get it to a tolerable level so that you can go on and function in your life. Pain management is everybody's job. It is the job of, if you're a registration person and you're coming to the patient's room to get them to finish signing consents, and they tell you, I'm in so much pain, please, can you get my nurse? You should be shamed if you tell the patient, okay, I'll get your nurse, but can you just sign these papers? No. Pain is what the patient says it is, and it needs to be addressed like it's an emergency or have some sense of urgency about it. Not only is it good for the patient and their health outcomes, but also, it helps you establish a rapport. You start turning down people for pain management, your whole shift is gonna suck. These are just the 4 P's of pain management, basically. One, you want to prevent pain. You want to treat the psychological aspects, obviously the physical painful, feeling that they're feeling. And then there's pharmaceutical, obviously you're going to give them the drugs. So non-pharmacologic approaches to pain, we already pretty much said that, distraction, acupuncture, going to a chiropractor and getting your neck popped all different ways, massage therapy, I don't know, random herbs and things, all non-pharmacologic approaches to pain. These can be beneficial for people with chronic pain or less intense pain, but usually you're using this in addition to some type of pain medication. You're using this to maybe enhance the effects of the pain medication. But in all honesty, pharmacology, I mean, this is Western medicine, people. Medication is the #1 approach. It is, like your book describes it, I think, as the mainstay. Mainstay meaning it is the #1 recommendation for pain management. The approach to medications should be, it should be based on what caused the pain. I mean, if you stubbed your toe, do you need Percocet? Probably not. But if you just had your leg amputated, yeah, give me the Dilaudid or whatever else you got in that cabinet. So it really depends on what caused the pain, prior experiences with pain. And with prior experiences, you might also want to add in allergies. Prior experiences is, have you had this pain before or similar? What medication or approaches to pain work for you? Some people tell you, I can't, well, for me, Tylenol does nothing. I'm not taking Tylenol, but ibuprofen, oh, baby, that's my drug of choice. So everybody, different strokes for different folks. It's what's worked for you in the past. Also, you want to consider the age and health status of the patient. If they're having kidney or liver issues, that can prolong the effects and it will increase the risk for overdosing because that drug is being filtered out of their system much slower. Obviously, you want to provide effective and safe analgesia. Analgesia is the medical term for pain relief, hence why pain medications are called analgesics. You want to get the best relief possible. Routes and dosing, again, can affect the outcome. Larger, obviously, the more the medication, the greater the effect. But you want to use the least amount possible to achieve. Once you realize a good dose, you don't need to go above and beyond. Like if ibuprofen 400, like significantly reduces their pain, you don't need to give them 800 milligrams. Why? 400 worked. Because remember, you took pharmacology, every drug has a side effect. You don't want to just be giving people more than they need with any medication. You know, the least medication, the better. Oral medications obviously take the longest to work. When you take a pill by mouth, it's got to travel down your esophagus, go into your stomach, it's got to get dissolved, it's got to be absorbed into your, so it takes about 45 minutes to an hour, real talk, for an oral pill to take effect. So it may not be the best option when you're trying to treat someone whose pain is 10 out of 10 right now, unless you have no other choice. Suspensions, by suspensions, I mean syrup, you know, the kids' medicines, the liquid form of oral medicine is obviously already broken down, so it's going to get absorbed faster than pills. Sub-Q, which is like your insulin injection, is going to work quicker than oral. Intramuscular is much faster than sub-Q or oral because it's going, you know, there are all those blood vessels in your muscles. Same with like, I didn't put it in here, but sublingual, giving it under the tongue. Again, it's going to get absorbed a heck of a lot quicker. IV bolus meaning you're pushing it through the IV. IV is obviously the fastest acting. However, think about it this way too. The faster onset the drug starts working, the faster it wears off too. So IV drugs work fast, but they also wear off much faster. Whereas PO medications, they do take a long time to work, but you're gonna see the effects lasting much longer than IV or IM. Obviously, you want to start from the lowest, so non-opioids, start with non-narcotic drugs first, And then if they don't work, then you advance to an opioid. Once they're on the opioid, what you want to do is gradually get that dosage down, titrate it down. That means you keep reducing it at little intervals until you got the least dose possible, or you got them off opiates completely and on to just NSAIDs. A PCA pump, that's what this is a picture of. It is basically an IV pump that also has a little remote control attached to it, which you see right there, that little button. And that is for patient-controlled analgesia. They usually get it after surgery. And it's basically administering a little small dose of a narcotic drug in short intervals as the patient pushes the button. It is, foolproof. It has a lockout. It won't allow you to get so much medication within. It'll have a lockout, like it'll say, okay, morphine 0.2 milligrams every 10 minutes with a lockout of 2, meaning it will not allow you to administer more than 2 total milligrams. So you're getting 0.2. So that means in the span of, I think it's an hour, you can only get up to like 10 presses, and then you have to wait that lockout. The lockout period, the dosage, the period, it's different. It just depends on the patient, the drug, and what the doctor orders. And the thing about PCA pumps, nobody should push that button except the patient. It is patient controlled, not their mom, not their dad, not their wife, not you as the nurse. Nobody should push that button but the patient. Non-opioid pain meds, again, appropriate for treating mild to moderate pain, and can also be used in conjunction with opioids to reduce pain. Tylenol is the most often used, and it is actually, older people do, they say it works really good for arthritis. It's the #1 treatment, the first treatment for arthritis. And it's the only drug that, one, is safe for pregnancy and can be given to infants. You cannot give a baby less than 6 months old ibuprofen. It's Tylenol up until 6 months. And for those, not for babies, obviously everything's weight-based in kids and babies, but in adults and adolescents, anyone weighing more than 50 kilograms, like 100 pounds, 4 grams is the maximum a person could take in a span of a day. So while you may see a dosage, or order for the patient can have 1,000 milligrams every 4 hours, after giving them a 4th dose, you can't give them anymore. So that leaves 8 more hours in the day, but they may be maxed out if they've already taken 4 grams. Why? Because Tylenol can cause severe liver damage and liver failure. NSAIDs are ibuprofen, aspirin, and these other drugs listed here. They work by blocking the production of prostaglandins, which were those chemicals that are released by the body. They're not to be used with anybody with a history of any GI issue, GI bleed, ulcers. Why? Because NSAIDs cause erosion or wearing down of the lining of the stomach. NSAIDs, because of the stop production of prostaglandins, they also cause blood vessels to dilate, and they decrease your clotting. So your blood is going to be thinner when you take them. So you don't want to give it to anyone who's at risk for bleeding. That means like even a hemorrhagic stroke. You are not going to give someone who has bleeding on the brain any type of an NSAID. It's only going to worsen the bleeding. And then same goes for people on any blood thinners. You have topical, other non-opioid drugs like topical, I don't know why well, fentanyl is not really, considered in the opiate class, but it's still a high risk drug. Okay, so I didn't mean to put it on there. I just put it there because it was topical. But topical means it's absorbed through the skin. Obviously, you have lidocaine patches. You can go to the store right now and buy some Oragel. Those are other approaches to pain. Tricyclic antibiotics, antidepressants like amitriptyline can sometimes, when they use anything like anticonvulsants or antidepressants, what I want you to remember, just remember those drugs work on the brain. Therefore, what type of pain do they treat? What do you think?
Neuropathic.
Yes, neuropathic pain. That is when you use, obviously gabapentin or Neurontin, you see that used a lot that's like the #1 go-to drug for neuropathy. So anticonvulsants, antidepressants are usually used for nerve pain. And then you have muscle relaxants, anti-anxiety meds like diazepam, which we talked about before. It acts as a muscle relaxer. Ketamine, don't really see that in use. You may see it more with peds, but that is a sedative, and that is reserved, for more significant pain. Now to the opioids. Opioids work by acting on the central nervous system to stop basically the activity of nociceptive pathways. So with opioids, you really want to monitor for adverse effects. You guys took pharm. What's the main thing you want? What are you watching with opioid? Respiratory, right? It causes respiratory depression. So you want to monitor and make sure, are they breathing? Are they breathing, the appropriate respiratory rate? Is their oxygenation okay? So opioids, that's that. Physical dependence, usually you have to, so when people talk about, I don't want to take that, I'm fearful of addiction. Okay, if you're on Norco for 3 days after you have your wisdom tooth pulled, you're probably not going to get hooked to Norco that fast. However, things happen. But usually it takes at least like 2 weeks of, regular use for you to have some sort of physical dependence. And that physical dependence obviously is when people have withdrawal symptoms. Tolerance, it again happens with regular use, and that's tolerance. Your tolerance built up, it's not having the same effect it used to, and it requires a higher dose to get the effect you want. Considerations for kids, just knowing those scales, again, the assessment tools, the age appropriate screening tool, and for kids, they say 3 months. NSAIDs should be 6 months. NSAIDs is 6 months, but this is what ATI told us. But you normally don't give anybody ibuprofen before 6 months, so just write that down. Second step for children is, and I think they just put that in parentheses based off your, those are the 2 meds you should go to first. For a child of any age, you're not going to jump to morphine usually. However, if they're having moderate or severe pain, one thing, sickle cell crisis, you may see a 2-year-old in sickle cell crisis getting morphine. And that is why a lot of patients with sickle cell do grow up to have issues with pain management, substance dependence, substance abuse, because they've been getting morphine basically since they came out of the womb. So it's almost unavoidable sometimes, unless you have a good provider and doing a lot of education. Obviously, for kids, you want to choose the least traumatic route. Oral, of course, is going to be your best choice. You know, you want to try to get them to just take it willingly by mouth versus giving them a shot. Because children may have a difficulty expressing their symptoms, then you want to schedule medications routinely versus as needed. So instead of saying the patient can have Tylenol every 4 hours PRN, it's probably just going to be scheduled that you give the child Tylenol every 4 hours because they're not able to really express their pain. And now we come to older adults. Older adults, obviously, everything's slowing down. So their kidney and liver function may be impaired just simply due to age. Because of that, it's going to cause that drug to linger. That's what I mean when I say prolonged effects. The kidneys and liver are not able to filter the drug out quickly as they would for a 20-year-old. So the effects are going to linger. So then if you give them another dose, 4 hours later, if you're medicating an older adult the same as you would a younger adult, you're probably going to see that by you come back and give them that second dose is going to have some effects on them. So dosing, like it says on the bottom, the dosing should be reduced 25 to 50% initially with adults, older adults, sorry. They also are at increased risk for GI bleed related to NSAID use. So NSAIDs are usually reserved for younger people. You try not